Welcome to On the Go, DocGo's podcast, where we discuss the latest trends in the healthcare industry and what we're seeing visiting millions of patients a year out in the field. My name is Bienstock. I'm the CEO of DocGo. Today I'm joined by Yong, the VP of Operations, who heads up all of our work with health plans and providers, and Dr. Jim Powell, who is the leader of our clinical practice group, overseeing our clinical visits happening across the country. And we're excited to be with you today. We've got a big topic on the books here. We're calling it gaps in care. The healthcare industry has a tremendous problem with gaps in care. I like to think of the healthcare space as a bucket with just leaky holes all over it, patients kind of falling out the sides. We're just not serving all of the patients in our healthcare system today with comprehensive care, and that's where DocGo comes in. We're going to see those patients where they are. Let's start with, what is a care gap closure? What is a care gap visit? Yong, perhaps tell us a little bit about what we do to address these gaps in care.
So I think a care gap is fundamentally, it's exactly what it says. It's a gap in a patient's care. Care gaps are typically focused around preventative measures, capturing risk up front and making sure we're screening up front and doing these things like cancer screenings to reduce the possibility of finding cancer too late stage. So gaps in care really refers to all those little preventative things that a patient should be doing on a regular basis, that they are, or on a episodic basis, that they aren't doing. And when you close that gap in care, you greatly reduce the negative health outcomes that can be associated with not doing a preventative screening or not closing a care gap.
And why, it makes sense why the patients would care about closing gaps in care, making sure that these preventative measures are taking place. Why do the health plans care about it?
I think there's two things. Number one, they are forced to think about it. They are forced to care about it by the government entities that operate these capitated plans, like Medicare Advantage plans or managed Medicaid plans. And frankly, even the marketplace members all have strict quality standards that the health plans need to adhere to. Health plans care because not only is it better for their members, which health plans care about, but also because it represents a giant opportunity for them from a business perspective. When health plans have high quality ratings, it really depends on whether it's an MA plan, a Medicare Advantage plan, or a managed Medicaid plan. But an MA plan, for example, has the notorious STARS ratings. The difference in premiums that a 3-star MA plan in LA County, for example, that's a part of a 3-star plan versus a 4.5-star member, the premium difference is about $1,500 a year. So it represents a massive difference for the same type of member, massive reimbursement difference for the same type of member that a health plan will receive from the government. So it's clearly a huge priority for them to be a higher quality health plan. Not only does it help with how they're reimbursed, for MA plans, it can be bonus payments and rebates. For Medicaid plans, it could be giving back some of the withholding that Medicaid, the Department of Health might withhold from a health plan before they see the quality performance. So financially, huge impact in the short term. But also in the long term, there are cost of care. Every health plan in 2025 is thinking about cost of care and their medical loss ratios. It is the hottest topic of the year for every single health plan. And one of the things that they're maniacally focused on is, how do we better manage costs this year and next year than we have in the past? And one of the big things with these quality measures and care gaps is, if you catch these preventative measures up front, over the long term, these patients aren't going to have all these undue clinical costs that might be associated with late discovery of a certain condition or a worsening condition. So both in the short and long term, from a financial perspective, health plans are heavily incentivized to close out care gaps, because it'll overall keep their population healthy, keeps the health plans happy, keeps the patients happy, and everyone's happy when the care gaps are closed.
One of the big kind of surprise moments for me was just how many patients fit this description. We've been provided with lists of patients, over 1 million patients. Hey, these are gigantic lists of patients that have gaps in care. have needs. Dr. Powell, you spent a lot of your career thinking about how do you serve the underserved, making sure that we're reaching hard to reach patients. Tell us why there's so many patients out there that have open gaps in care. What's stopping them from getting their health addressed? What's stopping them from seeking out medical care and closing those gaps in care themselves?
It's a great question. I think the answer is there's 1,000 answers for this. The problem we have is that I look at gaps in care as the window to a dysfunctional healthcare ecosystem. And that when we identify a patient, we're able to go into their home, it opens up the opportunity to find out where is the other parts of the dysfunction in the healthcare delivery, whether it's access, whether it's engagement, whether it's understanding. So quite often we do these gaps in care programs and we go into these homes and we see these individuals and we find that it's not just a blood sugar issue or a blood pressure issue, it's an understanding of what is their underlying medical issues, how they receive the support, and how they grow as an individual and enhance their ability to improve upon their health.
Right. And what typically happens? How do we get in touch with these patients, right? We talked about the health plans give us a list of patients that have gaps in care. That's where we come in, right? If a patient's being well served by the traditional healthcare establishment, we're happy for that. We're happy for that patient to continue receiving the care that they need in the setting that they're already comfortable in. But a lot of the patients, as we just talked about, there's 1 million patients, over 1 million patients that we've been provided that have gaps in care. How do you reach out to those patients? How do you connect with them? Clearly the system has not done a great job of connecting with them to date. So what do we do differently? How do we get a hold of these patients? And then how do we ultimately find our way into their living room so that we can close those gaps in care and get them the intervention and preventative care that they need?
It's a great question because it's one of the things that we're most proudest here at DocGo is our ability to engage patients. When we started working with health plans, it was very clear and apparent that one of their biggest headaches were patients that they weren't able to engage with their traditional provider network or their virtual care management team. Health plans are heavily focused on engaging their members. It's just that there are limitations to what they can do. So there's member incentives and provider incentives that they offer, but there's no amount of incentives that's going to reach a certain pocket of these populations. So we as DocGo saw this problem, started working with the health plans, and recognized that patient engagement has to be a core capability of ours. Our ability to get patients to engage with their own healthcare or say yes to a provider visit when they've never said yes before or they haven't thought about saying yes before, that needs to be one of our superpowers. And we've indexed very, very heavily in terms of where we spend our resources to make sure that we have a really clear, differentiated approach to patient engagement. And we take probably the most data-driven, statistically sound approach to patient engagement that I believe exists in the healthcare ecosystem here in the United States. Mm-hmm. I think we are best of breed in terms of our approach. And what I mean by that is we take everything into consideration. Like you mentioned, Lee, we have made millions of phone calls. And from these millions of phone calls, with every single call, we've been looking to learn something. What time of day should we call this particular member demographic, who is of a certain age, a certain race or ethnicity, in a certain income, low-income neighborhood or a high-income neighborhood, with a preference for a very specific language? What time of day should we call them? What day of week? What agent should call them using which script? What collateral should we send that patient 1 to 2 weeks before we make that initial contact to make sure that there's that brand recognition so that they're willing to pick up the phone when they see a DocGo caller ID or they see a voicemail that says DocGo partnering with your health plan? And so we have all these insights and tricks up our sleeve in terms of how to activate a member that traditionally health plans have really struggled to engage. And I'm really proud of the approach that we're taking. We're A/B testing constantly in all of our approaches. If we're going to send snail mail collateral to a patient, we try to understand what happens when we vary the image in multitudes of different ways. And we try to understand, is there a differentiator that we can identify to make the propensity of the patient to say yes to a home visit incrementally higher? And our performance speaks for itself. I think over the past 12 months, we've increased our ability to engage patients within our populations by more than 200%.
Yeah.
And it's something that we're really proud of, and it's one of the main reasons why health plans keep coming back to us.
The experimentation is fascinating. And really the insights that we glean from these experiments have been pretty surprising. I mean, one of the things we're so proud of is we'll engage with the patient with all different types of communication channels, text messaging, phone calls, mailers, email, all different types. There's a different cadence that we'll deploy. There's different imagery, different messaging, depending on the patient demographics. I think we're sort of really experimenting, and I think we're learning that the status quo, or what you might have intuitively thought would be the right way to do things, are really not the right way to do things. I mean, the story I love telling is we were maniacal. We were focused on, hey, the day that postcard lands, let's call that patient, right? It makes sense. They get the postcard in the mail, we follow up that day with a phone call. And apparently that's not the best outcome. The best is let the postcard drop, let it land in the patient's home, and then call them within a 2-week time frame, not the same day, which is what you'd not necessarily think, right? The day it lands is the day you should call, but we are finding that we perform better when we call 2 weeks after that postcard arrives, for whatever reason. Do you have insight into why that might be?
We always have our theories on why patients behave the way they do, but in particular, when it comes to Medicaid and Medicare Advantage populations, we realize that they may not check their mail as often as you and I do, for example. And I love that our team has the wherewithal to not say, hey, yep, we should get the postcard right there a day before we make that initial call or text, but they have the wherewithal to say, you know what, the way we approach things here at DocGo is in a data-driven way. We're gonna test out 6 different cadences and see what works best. And I'm going to tell you, Lee, there's a lot more tricks up our sleeve in terms of where that's moved on since you've last learned that insight.
Yeah.
And we're excited for learning more and more.
Yeah, I love it. We get the list from the health plans, and then we work to engage the patient, set up the visit. So we do everything end to end, right? We'll engage the patient, set up the visit, go and perform the visit ourselves. We're not subcontracting out to other folks, and then we're following up with the patient. So we're very proud of that. There's a lot of learnings that are going on in terms of what modalities work the best, what communication channels work the best. It's very fascinating work that I think we're really at the bleeding edge of.
And there's additional strengths that we haven't even realized yet that I've seen now, that the clinical trust is already there, because we've reached out in a way that makes the patient feel comfortable. The scripts are done in a way that's embracing. So when my team is now in that home, they already feel like they're part of that opportunity to drive healthcare. So it's not adversarial, it's not transactional, it's a value-based proposition. So we're going into that home based on the work we've done ahead of time to make the patient feel that we should be in part of their life and part of their healthcare experience.
It's a great point.
Jim, why do you think one of the days I spent on the phones, I called patients, the team loves to recount that. And I was on the phone with a patient who told me they had no idea who their doctor was, right? And I was curious about that because the health plans are telling us that every one of these patients is assigned a provider. But I found a lot of times the patient didn't know they had a primary care provider, or didn't know who it was, or hasn't seen them in a year.
Right.
Why is that?
Well, we have this kind of term, we talk about patients in general, that they're actively engaged with a provider, they've drifted from a provider, they haven't seen them in 12 months or more, or they've been assigned, but they've been unattached. And there's a huge number of those patients that have someone on the back of a card or on a website or in a portal, but they have no idea who that person is, how to get in touch with them, how to even access those services. And the patient and the provider are both missing out on opportunities to kind of create that bond and glue that creates what we talk about, the primary care experience. And so for us, it's not uncommon at all. In fact, when we go into homes, we talk about the environment of care and PCP relationships. We go and we talk to them, we find out that they have not seen this provider in months, if not years, and they may not even know how good or bad that provider is. And some of them are phenomenal, and we know them by name because we see the types of care they provide, but they just can't get into that home. They can't get into that service, or their hours aren't that good. We have people who work, night shifts, day shift, 2 jobs, so they can only get services on Sundays. And how many providers have office hours on Sundays in primary care? So these are things that we're seeing that's why we really bridge that gap of availability and access that really wasn't there for a lot of these patients before.
Right.
And patient attribution is just in general something that I think just needs to be improved. It needs to be better. If you look under the covers in terms of how patients are actually attributed to a provider, which means they have that PCP relationship, it's crazy. It is wild, it is appalling. There is so much bizarre logic that happens across all these different health plans that are unique in their own way. So certain, if you're in a managed Medicaid plan, for example, you have to have an attributed PCP. So if you are on a managed Medicaid plan, you have a PCP. Now, how do you get that PCP? If you've been seeing a PCP and you have a great relationship with a provider, that provider is going to naturally, automatically become your PCP in the payer system because you've seen them the most, they're the most last person you've seen, they're the last PCP you've seen, they're the most frequent PCP you've seen, and they may be geolocated near you. But let's say a patient comes and joins a Medicaid plan without a provider relationship that's going to show up in the claims for the health plan. What happens is the health plan just takes a look at the member, where's their home address, and they may just geolocate the closest PCP who's at a certain quality level, and they'll just say, oh, this patient, you joined our health plan, we're going to link you up with this PCP. Now, is that PCP going to reach out to that member proactively in the same fashion that we do? Probably not. Probably not. And that's one of the main reasons why a lot of our patients just have no idea who their PCP is, even if we say, hey, your PCP is Dr. Howell. He's right down the street from you. And our patients are, I had no idea. No one ever called me, no one ever told me, and I've been on this plan for years. I just go to my urgent care, or I go to the emergency department for my care. That's wild.
Yeah. I want to talk about the patient experience. I want to talk about the health plan experience that's working with us. I want to talk about our clinicians in the field, what their experience is like. You know, we're going to say it now. I hope you guys are okay with it. But I've seen both these guys tear up talking about, they're tough guys, but I've seen them both tear up talking about some patient stories of what we've been able to do for some of our patients. Both have gotten emotional. So I kind of want to hear, one of the things we're most proud about is just how much the patients appreciate the service we're providing, appreciate the care we're providing. We have a Net Promoter Score, which we track very carefully, 90 plus, which is unheard of in healthcare. And the visit feels very bespoke. It feels very elevated. It feels very customized to the patient need, and we get a lot of great feedback from that. But maybe each of you guys share kind of one story. You don't have to tear up now. You know, the cameras are rolling. But tell us one story of one of the patient visits we did. What was the condition of the patient? Who was the patient generally in terms of their demographics? What were they struggling with? What were their gaps? And what do we do for them?
Sure. So we had a patient in California, one of our new plans that we started with, and we go into the home. This is the story I get upset about, so I'll try to do it without getting upset this time. And this patient's blood sugar was in the high 500s. And unfortunately, that individual most likely would have benefited from going to the emergency department. Let's get them IV fluids, let's get their blood sugar down, let's get them to feel a bit better. Unfortunately for this individual, they were concerned about ice. And they were afraid if they went to the ER, they would not coming out. And so we had to figure out how do we kind of treat this patient not just today, but think about creating a relationship for them down the road. And that's where we got emotional about it because, okay, the best thing was the ER to get IV fluids, but what can we do in the home? Adjusting their meds, pushing IV fluids, knowing that we're not going to lower their blood sugar today, but if we can come back in a couple of days and get some blood tests and support them, over the next couple of days, we'll create a relationship and then ultimately their blood sugar will feel better and they'll trust us and trust the healthcare system.
Yeah.
So as you can imagine, you learn how to treat high blood sugar. You don't learn how to treat high blood sugar when someone's being afraid of being deported. Like no one teaches you that in the healthcare ecosystem. So when we talk about how exciting this job is, it's not just the black and white of healthcare. It's the SDOH, it's the fears, the behavioral health issues, all these other variables that create opportunity for us to really do a phenomenal job.
Yeah, so they're afraid essentially of, for whatever reason, they're afraid of the traditional healthcare establishment, and we're sort of bridging that, meeting them where they are. I love that. What about you, Yong?
I think my favorite story is, I get so many great patient stories around, oh, hey, this patient has fibromyalgia, they missed like 6 appointments with their provider because they're in so much pain, and we did something amazing for these patients. But I have to go with a personal story here. I think it is an imperative for leaders in positions like us to make sure that we are riding along and making sure how care is delivered and that it's up to our quality and up to our standards. And so I frequently go on ride-alongs with our nurses and interact with our patients. And on the most recent one that I went to, we had gone for a gap closure visit for a 75-year-old Black patient who prefers to speak Spanish. And our entire care team was culturally really in tune with that person. We had our provider who also is a Black family doctor who understands like all the nuances of care. And then additionally, our nurse was also Black and came from a similar background. So as soon as I walked in the door, there was a very different, it was a moment for me where there was all this discussion. A lot of it went over my head about specific supplements that they were taking, but our nurse initially just had this really long conversation with her about, hey, yeah, you can ask our provider, our doctor, about all the supplements that you're taking. She will understand what type of supplements you're taking if you just give the name. And when we started this conversation, this patient started opening up and started saying, you know what, I gotta say something. I hope you guys don't treat me like I'm this thing in a factory line. And I was like, what do you mean? Have you seen us before? Have you had a bad experience? She's like, no, I just know that in the past 5 years, she said, since COVID, whenever she goes sees her PCP, whenever she goes to see any sort of doctor, that she feels like she is on a factory line, and every single person that interacts with her spends the least amount of time humanly possible that they can. And she's just walking down that factory line. She showed me a book where she had about 40 questions written out. And she's like, this is a book that I've been keeping for the past 3 years. I'm my own PCP. When we asked her, who's your PCP? I ask my own questions, no one answers them, and I just know what questions I need answered. And so our provider joined, and oh my goodness. She brought out, our patient brought out about 30 supplements, asked questions about every single one of them, and whether there were negative interactions with their medications. Our patient was talking about a procedure that she has due a week from now because of a hip replacement surgery that she had a year before, and she's in chronic pain since, and she had no idea what the procedure was for. So our provider contacted the provider's office that was going to do the procedure, and made sure that they are going to spend some time explaining the procedure to her, and also spent time explaining why that was happening. Hey, there's a slight misadjustment in your hip, and they're going to try to realign that a little bit. You'll have like this lengthy recovery period. And at the end of the visit, the patient literally spent about 5 to 10 minutes, emotional at times, just most of the time laughing with us, saying, hey, wow, I'm going to tell everyone about it. This is what I sort of imagine like a visit to be, a provider's visit where I can ask my questions, I can get answered, and I legitimately feel cared for, and I haven't felt this in decades. And that is a very special story to me.
That's great to hear. It's a lot of the things that we track is how long does a visit take? And obviously the longer the visit, the more expensive it is to administer it. But I'd love to hear, we don't stop a visit short. We don't limit the patient to a set number of time. We don't make it feel like they have 3 minutes, get all your questions in, and then we're off, we're going to the next exam room. That's one of the things we pride ourselves in. We're really investing in the patient experience. We're investing in the capabilities we're bringing into the living room. We are not necessarily going to shortchange that patient and try to limit the visit to a set number of time. We're going to be there, and we use all the routing and all the tech back end that we have to make sure that all of that harmony that's happening in the field is efficient. One of the things that I'm always curious about is maybe talk about our clinicians that are overseeing the visits, and maybe talk about our medical assistants that are in the home. We have really high scores. Like our clinicians and our medical assistants and our mobile health clinicians love working at the company. Why do you think that is? They love doing these visits. They love being in the field. Why do you think that is?
I think it just starts with the purpose, the purpose of what they do, and they really feel they're having an impact on care delivery, not just for that patient, but they love the idea of taking what we're doing, creating and growing it to new states, new markets, new regions. So to feel that they have an ability to have a stamp on the future of healthcare is a phenomenal piece. I think the other piece is like we set down a foundation of excellence of how do we train people and make sure they're eligible to conduct these visits. So providers at 60 hours of training to be able to understand all the gaps, understand the nuances, understand motivational coaching, understand how to embrace a patient, not just for this visit, but for future visits. It becomes really a big part of what we do. And then between the shadowing and the quality assurance and the oversight, people feel that, again, I may have seen 10, 15, 20 patients today, but I had an impact on the direction of healthcare, which is, you don't get that a lot. We're not a factory, we're not widgets. We're really deriving outcomes and opportunity.
Yeah, I think the biggest thing I hear from our nurses is purpose, purpose, purpose. One thing that I love to say is what we do, our care delivery in the home, must exist. Yeah. And I think that sense of purpose that everyone has around launching this new type of care all across this country is super motivating. But on the other side of things, I think nurses have so many reasons to love us. Number one, we typically provide super flexible schedules. They can work for us part-time, they can work for us full-time, they can work for us per diem. They just need to make sure that they have regular visits with us so that we make sure that their training is up to par and they don't forget stuff. But I think also there's just this, if you want to be a nurse in a doctor's office and all you do is take vitals and then you move on, this job's probably not for you. Right. I don't, what our mobile health clinicians do isn't really even squarely in the boundaries of what a nurse does. It's so much above and beyond that. So when nurses like a more dynamic environment, when they like going into a patient's home, into an environment that's not super sterile, every day the same, and they like, frankly, driving from one patient's home to another, those nurses tend to love us and they tend to stick around.
Yeah. So we talked about the patients, we talked about the clinicians that are providing the care that are at DocGo. What's with the health plans? It seems like every day the health plans are having challenges, there's policy changes. Clearly these members are falling through the cracks, they're falling through the leaky bucket. What are the health plans doing that you think is innovative, and where's the area for them to improve?
I think health plans typically get a bad rap, but I will say, just like anyone in the US healthcare system, everyone wants to make a positive difference. Yeah. There is no bad actors out there intentionally trying to hurt anyone, and that's what I see whenever I engage or talk to our health plan partners, is that everyone cares. Everyone cares about the mission that they're on in terms of better managing health outcomes of their population for everyone's benefit. I think being a health plan is a tough business. There's so many variables that you can't control. There's regulatory pressure. I mean, let's talk about for Medicare Advantage plans, after the most recent changes, there's never been less 5-star plans. The cut points have never been tougher to achieve. And it's just a really tough environment. And every year, it's not like CMS is making it easier and easier for these health plans. Right. And now all these new requirements start coming in, and not only from the government entities, but from private entities that have heavy influence as well. NCQA is coming in with new requirements around stratifying populations based on race and ethnicity. They have new requirements around social determinants of health related screenings. And so there's all these changes that are happening externally that these health plans have no choice but to respond to. And then what they can do with their existing providers and their existing members is sort of limited. You can offer incentives for your members to go get their annual visit or a colon cancer screening done. You can incentivize your providers and pay them like hundreds of dollars to complete some of these visits. It's just the way we've built the system, the providers don't have the capacity or the knowledge to proactively outreach these members. It's just not the way the system's built. So when health plans are struggling and they start seeing populations that they either can't engage or care gaps that they can't close, or people getting admitted into or readmitted into inpatient departments or into hospitals, they look for innovative partners everywhere. I will say I haven't yet met a health plan that is not willing to try something. Every single health plan client that we work with are actively looking to make a difference and figure out how to tweak the math a little bit. And that's where we come in. We're one of those innovation partners, and one of the things that I love with how we partner with our health plans is we're not this company that says, hey, here's 5 widgets, what do you want to buy? We typically say, we have this broad-based platform and capability in what we do and how we do it. We can engage patients better. We visit patients directly in the home without forcing patients to come to us. And within that model, we innovate constantly with our health plans. And so I think, number one, being in health plans is a really tough business, that there are things that they can control and they can't control, like medical costs. How are you going to control for COVID? How are you going to control for the aftermath of COVID and when people take elective procedures? Right. So there's a lot of like complicated things that go into a health plan, and I think that forces health plans to constantly look for innovation, and generally speaking, they do that through new partners, just like us.
Jim, over the course of your career, do you feel like people have more gaps today than they did 20 years ago, 30 years ago, or the system is getting better, there's just lots of room to improve?
The gaps are always there. I think we're better at identifying them and being more innovative in trying to fix them, but they were always there. And I think the one of the biggest flaws is there was no real true scheduled visits, preventative outgoing efforts to make someone come in on a regular basis. So because of the sick visit, ER, hospital follow-ups, we lost that ability to do a lot of those gap closures. So I think there's the enhanced awareness of it that I would say. And I think what we're finding with these gap closure visits that we're completing is all the additional piece, to go back to your question about what do the payers get, is they get the added bonus of what we do. So for example, we have a bone density program where we go into an individual's home and do bone density after they fall and to see if there's any risk of osteoporosis. But we don't just give them the results of the bone density, we let them know what meds they're on that can increase their risk, what's their mobility in the house, what's their Morse fall scale, all these things that we give back to the payer, and we fax it back to their PCP. It's not, here's your result of your bone density. Here's a plan that helps improve the outcomes of that individual. And I think when we talk about the payers, what they get excited about us is that, again, we're not transactional. We're going to give you extra value to those services. And that's why I think our program is really continuing to grow the way it is.
Yeah, and just building on that and tying it back to something we talked about earlier, that engagement level insights that we derive them at the aggregate level, but also at the health plan level, because every health plan membership behaves very differently. It's sort of shocking how differently health plan members behave across geographies or even within the same geography. And so one of the things that we love to do in terms of not only sharing what we share back above and beyond what we were tasked to do by the health plan, is we love to share back our engagement insights as well. So not only will we give above and beyond clinical insights, we'll give above and beyond engagement insights as well. And I think that's also one of the reasons why health plans love to work with us.
That makes sense. Do you think one of the big reasons why we think care gap closure and working with the health plans is so transformational is that the system over time is going to move to incentivizing providers and companies like ours to make patients healthier versus incentivize and reward them for the more tests that they do or the more visits they conduct. Right. So what's stopped the industry to date? It seems so obvious, right? If the patient's healthier, everybody should be rewarded for that. Whereas this whole system is set up kind of to be a sick system where the sicker the patient is, the more tests the provider does, the more inpatient visits there are to the hospital, and so those organizations make more money when there's more tests and more visits. We're trying to put it in a way where reward us for being successful in closing gaps in care. Reward us when patients are healthier and stay out of the hospital. It seems so obvious. What is stopping the industry from moving full boat to that?
I think it's short-sightedness. I think it's being scared of losing a member in your health plan before they get healthier. So a lot of the care gap, the care gap measures that we talk about that we close in the home, they're not going to show up 6 months from now, or some of them do, but generally speaking, a lot of the measures that we talk about are very, have a very long date, long horizon that we're looking at. If you get your annual wellness visits, we're going to understand the chemical imbalances in your body better than someone who doesn't, and we'll better understand your chronic conditions, and generally speaking, we expect to better manage that person's health outcomes over the long run. So I think one of the reasons why people aren't indexing so much towards preventative care is because the incentives aren't there. And when people are thinking through the incentive structure that exists today, if a member that you help, add another year of life to, like 10 years from now, if they churn out of your Medicaid plan and go to another Medicaid plan, you don't get that benefit. So I think there's really some structural changes that need to happen for everyone to be incentivized to do the right things.
That no one's talking about this. I think we really have to emphasize this. I think this is a profound insight in that there's a lot of short-term incentives in the healthcare industry today, which is shocking. When people think about their lives, they want longevity, they want long-term health and happiness, but the whole system is set up for short-term. Not enough people are talking about this right now, right? So as a health plan, if you're able to help a patient lead a healthier life, those savings may come 3, 4, 5 years down the road. They may not even be a member of your health plan anymore. So are you incentivized to really impact their health 5 years down the road? That's a major problem. I don't know how we fix it. I mean, I think we have our role to play, but no, that's the quiet part that people are not saying out loud. There is not enough long-term incentives in the system, and I think we're uncovering that. I mean, we really sit at the nexus. We work with the health plans. We're in patients' homes. You can't get more intimate than that and a deeper insight into the patients. And then, of course, we're providers ourselves. So we have a really interesting viewpoint, and I think that insight is one that very few people are talking about, but I think it is a very profound insight, because if you are incentivized for long-term health, which is really what everyone cares about, then perhaps we fast forward to this value-based, you get rewarded when a patient's healthier outcome. But right now, everything's set up for a short term. They're on your health plan today, they may not be on your health plan tomorrow. They live in your neighborhood, they may be in your hospital health system today, but they may not live in that neighborhood anymore. They may move somewhere else. And so the short-term incentives don't work, I think. And we have to try to, if you're a policymaker, absolutely that's probably the area where you need to target, at least from where we sit. We see it day in, day out. We're there side by side with patients in their homes. That's the way to solve it. What do you think, Jim?
Well, just to add that, which is fascinating, when you think about the institutions and the hospital systems themselves, team program starts next January. So that's CMS's program about surgeries and readmission rates and savings. We've talked to a lot of health systems. I don't want to give a percentage, but many of them aren't even that interested in thinking about what they want to do for 2026 because it's only upside risk until it gets down the downside. And to your point, that the PCPs are supposed to be the gatekeepers of healthcare delivery. They're supposed to guide the services, supposed to guide, and in theory, they should be rewarded for that. But the PCPs are the ones doing all the documentation, helping out, facilitate, trying to create these quality touches for the patient and the healthcare journey, but they're not the ones being rewarded. So I think finally, that kind of FQHC model of you own the relationship, you are part of the PCMH model is really coming up. But I still think it's going to take some time.
Yeah, no question about it. No question about it. So if you had one insight, we just talked about the long-term and the short-term incentives, but if you fast forward a year from now, what are you hoping to see from our health plan partners, from patients? What are some of the goals and some of the initiatives we're looking to implement in the field?
I think the biggest strategic objective for the health plan partnerships team here at DocGo is really focused on catching the members who require that longitudinal relationship. In some of our programs with payers, I don't like the word episodic, but they tend to be, we visit the patient once, we complete a procedure, and then, or we complete a service, and then we see the patient maybe next year if they pop back up on the patient's list. While we are doing these types of care gap services in the home, so many of our patients who are experiencing not needing to wait inside an exam room or in a waiting room, but they can just wait at home. And especially for our patients who might have, for whatever reason, challenges going outside or ambulating or accessing care, when we come to their home, in the comfort of their own home, in their living room providing care, while they're just waiting, watching TV while we join, there's something very magical about that. Once we're engaging with these patients really love us. Our NPS scores with some payers, it's at 100, I don't want to jinx it, but like almost every single patient that we encounter in their home absolutely loves the experience. And what happens is the patients have started to ask us, hey, can you be my primary care physician? Hey, I'd love to talk about the medication that I'm on. Can we have a discussion? And when we started experiencing this, it became not only like a clinical imperative for us to provide care for these patients, it also became more of like an operational imperative for us as a business to say, hey, we're gonna make a difference in that longer term. We're seeing the gaps that we can fill. We're seeing the services that we can provide that the existing healthcare network cannot, and that's what I think is super exciting for next year. We're gonna start providing longitudinal care for patients who really need it from us, and who would prefer it from us. And I think we're going to make a profound difference in the lives of patients and the financial operations and financial performance of health plans that we work with.
Yeah. What do you think, Jim?
Yeah, and I would add to that, I think we're collecting data that was never available to me in 20 years, that I'm looking at the medical, the behavioral, social, and financial wellness of that individual. So now we're looking at how involved they are with the community-based organization. We're looking at their transportation. We're looking at their delivery pharmacy, variables that I only dreamed of being able to have access to. So now as we kind of create the plan and put the patient center of the plan, we're going to also understand some of the variables that we can modify to improve those outcomes, because prescribing a medicine is great. Taking it is better, understanding why is even better, and what are the variables that are inhibiting that. So now with the data and the way we're leveraging information, because we're really on the forefront of really extracting all the health information exchange information, all the data within the ecosystem that's available to us, I think we're gonna have some really, really powerful results coming up.
Totally agree.
Yeah, well, I think, look, we're at the vanguard of this. We're engaging with 1 million patients, going to see them, addressing gaps in care. People love to change the name of our industry. It's the healthcare industry. They call it, it's the sick care industry. We only care for patients when they're sick. To me, I think maybe we change the name to the health gaps in care industry, because there's so many patients out there that have gaps in care. You know, we're the ones doing something about it. There's a lot of people that are putting a lot of great thought and care into how we reach patients that have gaps in care, and hopefully that number gets smaller and smaller as the years go on, and we're providing longitudinal care for those patients and keeping them healthier, so it can be the healthcare industry, not the sick care industry. Okay, so one of the things we didn't talk about is really the health plans are under a lot of stress right now, right? Their MLRs are going up, their costs are going up. And so one of the things we do is we approach the plans and we say, we can actually help you manage your costs. You can actually invest in our programs, which will ultimately lead to healthier patients and drive the cost down. How do we help the payers save money?
There's a couple different ways where we help payers save money. I think it depends on the product or program that we're launching with the payer. So for example, in our transitional care management program, where it's been proven to reduce readmissions, we save the payers money by reducing readmissions, which can be very expensive. They can cost somewhere between $15,000 to $20,000 per readmission, and we reduce readmissions by somewhere between 30 and 50%, depending on the cohort. Massive cost savings for the health plan. With our primary care program, we believe that we will make a huge difference in the patient populations that we serve that have typically been less engaged with their healthcare, and we're gonna produce a massive savings in some sort of shared risk arrangement or value-based arrangement that we have with the payers. Yeah. In our care gaps, as I mentioned in some of our quality, the quality and care gap discussions up front in the beginning, it can have a tremendous financial impact. So the difference between half a star in an MA plan is massive. The difference between quality ratings in a Medicaid plan, it could mean the difference between 5% or 7% of your revenues getting withheld and given back to you. So there's some massive, massive financial impacts from a quality ratings perspective. And the way health plans typically work with us is their health plans know exactly which measures they are unlikely to hit. They'll be tracking all the measures that are important to them, particularly ones that are more than single weighted, and they'll be like, hey, if I can get 200 more bone density scans on women over 60 who've had a fracture in the past 6 months, we might go up half a star. Or it might be a combination of those. Hey, we just need 1,000 more annual visits in our population, plus 100 or 200 more bone density scans, and maybe 100 diabetic eye exams, and maybe like 30 A1C checks or controlled A1C care gaps. And so when payers are looking at this problem, historically what they do is they use their own telephonic outreach teams that are nurses that are trying to close out care gaps over the phone. They try to incentivize providers or members, but once they start working with us, they start realizing, oh, we can literally give them a list of all the patients that we don't believe will have this care gap closed, and DocGo is going to make a difference. And I can say when to stop, although payers never say stop, but even after we help them reach their goals. So from a financial performance perspective, quality has a huge impact, and it's so case by case and idiosyncratic per each payer. But the amount of impact that we can provide by closing out care gaps is tremendous.
No question.
I would also add the VFC program, because it's a quality measure for these well-child visits to try to get these vaccines into these children. And because we set up a VFC program, it does not come out of the health plan's budget. It comes out of the federal government's budget. So not only improving the quality of this care, but it's actually not costing them to do this. And it's a lot of work to set up a VFC program in multiple cities, which we've done.
Oh, yeah.
And we are probably one of the largest VFC providers, you know, in the country in terms of numbers. And I love your story about taking the kids out from and bringing them to school and bringing them back the way you describe vaccines, that we need to make sure a vaccine is safe. It goes out to the home, it's administered, or if it doesn't get administered, it gets back safely and there's no temperature excursion. It's a very, very involved program, but we're so proud of it because, one, the payers love it, two, the patients love it, and then three, it validates all the quality metrics that we do, because we have 50 different metrics that we do in terms of improving gaps in outreach and effort. And having that solidified, value-driven VFC program that has to be verified and audited and checked by the Department of Health, we know that the health plans realize the value of the other services we do.
It's huge. So this day and age, we have to talk. I'm being told we cannot exit a podcast discussion without talking about AI. So, look, one of the things I think we pride ourselves on, we have a tremendous technology back end. We're constantly innovating, building our own proprietary tech systems, and our tech platforms really enables us to do what we do by bringing care to where patients are. But we're absolutely embedding AI into how we go and provide patient care. So maybe, Dr. Powell, talk about how we're using AI in the clinical setting, and then maybe Yong, talk about how we're using AI for operational efficiency.
Yeah, so I'd say that, I mean, there's not a day that goes by that we're not using AI at DocGo, which is phenomenal, exciting to do. Even with the devices, like we have an AI device that we use for retinal imaging, and that allows us to get an FDA-approved reading of that image almost instantly, so that we can, one, validate it as a provider group, but then two, give that information to the patient. So the next steps. We don't have to wait for a day or two for someone to read an image. And hopefully you can get in touch with the patient who's already hard to get in touch with, and then say you need to see an ophthalmologist. We can have the information get right to them right there. So it's immediate access, immediate results, and immediate plans. That's probably one of the things that gets me really excited.
That's great.
Awesome.
What about on the operational side?
Yeah, I remember you said we're not going to keep our heads buried in the sand while this happens around us. We're going to be part of it, and we're going to be driving it forward. And since then, the Health Plan Partnerships business has been on an operational mission to figure out what we can do to improve our efficiency by using AI. There's so many pilots going on right now, but one of our product teams created an agentic AI that when patients have agreed to our visit and they have questions, they can ask this agentic AI, and this agentic AI has the background knowledge and has been trained to give them all this. Hey, I don't understand what's going to happen this visit. Oh, you're due for a diabetic eye exam visit. It's because we're worried you have diabetes and you might have diabetic retinopathy.
And this is an AI agent answering all these questions.
Absolutely. And the same AI agent also gives appointment reminders, and we have lots of plans on how we're going to upgrade it and use it for additional type of outreach and services. But look, we don't think agentic AI interactions might be for every single patient interaction. But we know for a fact that we can become so much more efficient, and patients are going to enjoy the immediate responses that are very well informed from our agentic AI agent. And we're very proud of where we come and looking forward to how much we do in the future.
That's great. Look, this may be a hot take, but I think if there are companies out there just building the software component, or here's an AI point solution to help the hospital systems or the health plans be more efficient, I don't think that's a successful strategy. I think health plans and hospital systems that we meet with, yes, they want to be at the vanguard, they want to be at the forefront of technology, but they also need a way to implement that technology. They also need a way to get that technology out in the field or in the patient setting. And I think our strategy of marrying both the services, part of what we do, we're the ones that go into the patients' homes. We're the ones that transport those patients. We're the ones that go and do the mobile lab collections and so forth. But at the same time, we also use AI to be more efficient. I think that's a winning strategy. I'm very worried about all these companies out there that are building AI point solutions but don't have a way to actually implement the innovation, I think they're going to have a hard time. I think the only way to be successful, or the primary way to be successful in healthcare, is to have both the technology, which we do, and the services delivery, which we do. And then we can actually implement that and bring it to market. That is an absolute crucial piece. And I hope I'm wrong. I hope everybody's successful. I hope everybody wins. I hope everybody does well. But I think ultimately you have to have the healthcare delivery, have the services, along with the technology. That's when you could have a huge impact. Appreciate it.
I love that. Thanks, Lee.
Thanks, Lee.